Now let's do outcomes. Outcomes also a very important part of these studies. What we want to make sure of is that we know if what we're looking at as far as outcomes are direct outcomes or clinical outcomes, surrogate outcomes, or composite outcomes. So, clinical or direct outcomes affect how patients feel, how they function, or how they survive. Versus surrogate outcomes is an outcome that's the indirect measure of a clinical outcome. These are the two major types of outcomes. We're going to talk about composite outcomes here in a minute. But for clinical or direct outcomes, what you're looking at is these are the hard outcomes that patients care about. Am I going to live longer? Am I going to have a heart attack? Am I going to have a stroke? Am I going to have more COPD exacerbations? These are things that we think of as being directly proportional or a direct outcome that the patient's worried about. Versus surrogate outcomes are outcomes that we assume are going to be directly related to these direct outcomes. So for example, we assume that if I lower blood pressure, that these patients are going to have better or less risk for stroke and heart attack. We assume that if we lower patients' cholesterol, again, you're going to have less strokes and heart attack. We assume with improvements in FEV1s that patients are going to have less COPD exacerbations and mortality. These are all things that are indirectly proportional to these direct clinical outcomes. And then our final group of outcomes are what's called composite outcomes. These are outcomes that where you're trying to combine multiple outcomes in order to, it's a combination of multiple outcomes. So that would be like whenever trials will talk about MI, non-fatal stroke, non-fatal MI, non-fatal stroke, thromboembolism, things like that. So they'll have all these different outcomes together. And if the patient has any one of these outcomes, it counts as one bad outcome. So you might be wondering yourself, well, is this a problem? Why do trials do this? So the thing is that if I were only to look at MIs alone, for example, I would have to have a lot more patients in order to meet power or in order to find a difference. Same way with stroke and same way with just thromboembolism. But if I put them together, these are all bad outcomes and we all agree are related to one another. But when we put them together, we can assume that if one of these things happen, we can count it as one bad outcome. So that means that we don't have need as much of a population. Here are some examples of surrogate outcomes and what we did, and the surrogate endpoint and the clinical endpoint that were used. So when evaluating outcomes, what you want to do is first figure out what the primary outcome is. Is this a clinical outcome? Because that's probably what's best, or a surrogate outcome. If it is a surrogate outcome, you do want to make sure that the surrogate marker is validated or a standard in practice. One thing I didn't mention about in this previous slide, these are all trials or all examples of trials where they used a surrogate outcome and assumed that it's related to this clinical endpoint, but later on it was found out that they weren't directly related. So for that reason, you do want to make sure that if it is a surrogate outcome, that it is a valid or standard in practice. The outcomes are usually found in the methods section, and it usually has either its own endpoint/outcome section as well. You do want to look up similar studies, FDA guidance documents, and other resources to determine if your outcome is appropriate.